Hello, hello, hello. This is Truth Be Told. This is Dr. Walter Aka. And once again, we are blessed to have I think Dr. Horton kept calling you guys sisters, but sisters, sisters-in-law or whatever it may be, but Dr. Lynda, Lynda and Krystle, Dean Duru. Thank you guys so much. What they're going to do tonight is just basically share their knowledge, share their experience, and basically allow us to understand more from the podcast episode. You know, I asked them kindly if they could just come on and basically give us more, give us something that, you know, we could take to our pediatric dentist, or we could just take to moms, you know, dads, whoever, just so that they can be more educated. So ladies, please, if you don't mind, let's go ahead and do this.
We'll take it away. Okay. Thank you so much.
No problem. Thank you.
We're happy to be here. We're happy to share knowledge, and we're just gonna give a little foundational knowledge first, and then get into a infant case, one of our special babies that we treated. So this quote here we really like, just because it's something that we hear all the time. Oh, he's just so lazy, or a baby's so lazy, and really babies are not lazy. They just don't feed well, or if they don't feed well from the breast, there is a reason, and we really do have to get down to the bottom as to why. So let's see. So again, breastfeeding is like a superpower. It goes beyond just simply satisfying the baby's hunger. And there's studies out there that, you know, kids who continue to breathe for more than, or not breathe, sorry, breastfeed for more than 6 months. I know they better breathe. They show the lower risk of sleep apnea compared to those who never breastfed. And that's just a small tidbit of fact of what the importance of breastfeeding. The other thing, we got some facts. So we are obligate nose breathers when we are born. And the most important kind of survival mechanism and reflex that we need to have is that suck, swallow, breathe when we come out. So that's really, really an important reflex that we first have when we're born, that sets the stage for a lot of things. And so a tongue tie can be seen in utero, in fact, 12 weeks in utero. And before the week 4 in utero, the tongue is functional. We mentioned in the podcast that the tongue is the second muscle group to develop after the heart. When you say muscle group, it's going to be turned into an organ soon, just because of how important it is. And whilst in utero, the baby is practicing doing a lot of motions, whole body motions, sucking, tongue motions, breathing, swallowing, a lot of gymnastics while in utero. So that's important to recognize and understand. And the other thing to understand is that birth is our first trauma. We go through a lot of motions and movements to get out of the canal, and a lot of those motions and movements start to affect the shape of our heads. This study here shows, I think when Dr. Horton said, this sounds like it's everybody. Yes, everybody has some kind of somatic dysfunction, and that's what this study is showing, that majority of healthy newborns, so it's not that kids are sick, it's just that when they come out, because they've gone through that journey, a traumatic journey, so to speak, that they do have some sort of what we call somatic dysfunction. And 95%, one of the findings is that condylar compression that we discussed, and we're gonna kind of go through what that is. You can she likes to make the movement.
That's right.
And so this is what we talk about here. The back of the head, when we brought the skull the last time, but here's a better understanding. The back of the head receives the most brunt force during delivery. And that study before shows that we have that compression. Majority of us have some kind of somatic dysfunction when we come out, and what holds or what nerves pass through the back of the head are the hypoglossal nerve, the vagus nerve. So the hypoglossal nerve is the one that governs the tongue, or one of them that governs the tongue, really important, and the vagus nerves that governs that rest and digest, goes to the heart, lung, digestive system.
Can you explain the somatic dysfunction, what that is, please?
What that is? So somatic, so pretty much your body, the body, your head, right? Say it again.
the body and the rest of
the
head and
the head and the rest of the body. Yeah, so that's what I mean when I say somatic versus like sensory versus like motor. It's like just the shell that we come in. And so the shell that we come in is mushy, is not, is very, it receives a lot of force and trauma when we come out of the birth canal, even as healthy human beings. So we haven't even talked about things like C-section, things like Pitocin and all of that, but just as healthy infants, that's how we come out. And so sometimes it's a brunt force that occurs in the back of the head, and those nerves sometimes get compressed. And those areas of the back of the head don't get fused until the child reaches age 8 to 9 years old. So imagine all the trauma that occurs, imagine everything that happens during that time. And so when there's compression of those cranial nerves, which is the 9, 10, 11, and 12, it can interfere with messages being sent. And so it can cause things like headaches, neck pain, trouble swallowing, trouble speaking. And that's the reason why we talk about whole body workers, because they're like the detectives that help to use gentle methods to help release some of that tension and compression and make sure that the baby can function. And then on our end, we use that baby lace, the non-surgical laser, which can help in the head and neck area as well. So that's that. So like I started to mention, what are some of the pitfalls and some of the extra traumas that occur? And so the extra trauma is, when when the baby has to get out healthy, okay? So, or has to just get out during birth. So the birth story is so important. Sometimes things like having extended labor with or without epidural anesthesia, a rapid delivery, C-section, forceful forceps or vacuum extraction, if there's cord wrapped around the neck, the acceleration or stimulation of birth using Pitocin, or if baby was breech. All these affect the optimal functioning of the baby in numerous ways, and that has to do with tongue function, breastfeeding, and digestion. And these effects can be seen and felt well into adulthood. And that's why in our intake, we're always asking about the birth story. So sometimes moms, for their 16-year-old, they're like, why are we still asking about this? It's important to know the entire story, because it gives us an idea of what could be occurring or what's going on. And so some of the signs that you do see if there is occipital condylar compression is things like nursing issues, difficulty sucking, difficulty swallowing, reflux, vomiting, colic. And colic is just an all-round term, a catch-all term. It's what we call in our field idiopathic. There's no actual reason for it. Just baby's fussy and it's inconsolable sometimes. Respiratory issues, constipation, bloating, torticollis, and irritability. So those are some of the signs that may be seen, and that we should be asking questions versus just like, oh, that's just baby doing baby things. So just a couple facts about how our face grows. It grows from the base of the cranium. What causes it to grow and helps it to grow is the function, which is nasal breathing as a function, proper nasal breathing, and proper breastfeeding, not nipple feeding, but breastfeeding. What helps the mid-face to develop, that's here, that's that tongue up and a functional swallow. What brings the mandible forward, that's the chewing, which is established at the age of 4 and 5 months. So during that time, we're still giving baby Gerber foods and mushy foods, and really by that time we should start having some more chewable whole foods to start developing the jaw. And then also that functional swallow helps to create the ball and socket joint of the TMJ, which helps to decompress the cranium. So like we were saying, that suck, swallow, breathe, nasal breathing reflex is extremely important for the neurology and just creating good foundation of function throughout the body. And then, like we said, as soon as nursing, very important, creates that oral volume, creates the space for teeth. The tongue being up helps to balance the muscle forces. So a lot of things that we're talking about, even though baby doesn't have teeth, it's the muscle function that really muscle function and tongue as well, because that tongue is really, really strong. It gives 500 grams of pressure. That's what really helps to form the face and form the volume that the jaws need for the teeth to come in where they're supposed to. And then we talk about neurology a lot because the nerves play a vital role in innervating the tone. That's what helps to expand the airway. Our airway is just soft tissue located behind the tongue. So if the nerves aren't functioning properly, they create a structure that hinders proper airway development. And then if we're not sucking properly, or we're not properly nursing, that also shows how well the cranial nerves are working. So it's not always just, and I think we mentioned this the last time, it's not always just a tongue tie. Nursing issues are not always just a tongue tie. That's why having really good evaluation is extremely important, to know when and when not to cut. And we talk about all these cranial nerves, again, really, really important. And the coordination of these nerves creates the foundation for human development and function. So we'll get into our case.
All right, and so we have the pleasure of presenting baby Javier. And he came to our office when he was a month old. And mom found us from Uncle Google. When she came in, I love our Uncle Google moms. She came in, she said, I want to have a tongue tie evaluation and I want some information on baby legs. Okay, lady, you're talking our language. And so again, we start out getting the birth story. He was born at 39 weeks, vaginal, non-medicated. He was occiput posterior, or more or less what's called sunny side up when he came out, which is usually not the typical way. And so he was born with his hands over his head as well, and had jaundice that cleared after 10 days. His birth weight was 8 pounds, 11 ounces. At the time he came in, he was weighing 10 pounds, 1 ounce. So he didn't have any weight gain issues. He did not have vitamin K shot at birth. For us, at that point, over 3 weeks old, it's not a problem. And he's currently breastfeeding, but mom's breastfeeding goal is to have him breastfeed for 18 months. And so, questioning, we go to mom, okay, what symptoms were you having? And she said, oh, I had a couple of times mastitis, and I have some soreness or discomfort, but nothing too major, which we find a lot of moms do. They just want to feed their babies, and sometimes even admitting that there's pain, there comes a little bit of not shame, but it's almost like I can't do this that is supposed to be natural. So they're not likely to say they have discomfort. So sometimes they'll tell us it's a little bit, but we know it's a lot anyway. And she had already had some body work for the baby and herself. And then she said it didn't help very much. But most importantly, she did not want to have any surgery, which probably is the reason she wanted more information on baby legs. So for the baby, and we said, what symptoms does this baby have? We found out that the baby had frequent spit ups, frequent hiccups. He was always feeding. He was not satiated because he was just making the effort to feed, and he's using as much effort as he's using to just get the food, and the food, he's hungry again. And more importantly, the mom said he had noisy breathing and his mouth was always open. There was also milk deposit on the tongue, which becomes important anyways. I'll tell a little bit more about that. So when we examined him, we had, usually we'll have the baby on the knee to knee with the mom, and the baby's head toward the provider's belly, toward my belly, or Dr. Krystle's belly. And then you first observe what the kid looks like. So you can see the picture of the baby here, and you notice the clenched fist and the open mouth and the head that is kind of turned kind of funky way. And so usually when that's happening, you're looking and you're thinking this kid must have torticollis. And so his mouth is open, his chin is way far back, is retruded or retrognathia. He had a lip blister and he's got a mentalis strain already, and his whole face was just generally asymmetrical, and he had full body tension, muscle tension you could feel. And then going inside of his mouth, you sort of see that, oh gosh, he's got a high bulk palate. The roof of his mouth was more like a cathedral. And then he had, yes, and then he had milk or white coating on his tongue. And I just go back to that. Usually they get that when the tongue is not able to go and self-cleanse to the roof of the mouth. And you want to distinguish that from thrush. If it were thrush, when you clean, it will just wipe off and have a red surface left behind. When you wipe it with, say, a soft cloth and it doesn't wipe off, it is not thrush. Anyway, so the other thing that we noted was check some of the reflexes, and he had mostly normal reflexes, and he had a lip tie, which you can see here, going there, connecting the lip way down to the alveolar ridge here. And he did have a tongue tie, but it wasn't just very obvious. You can see I'm pushing my finger in all the way to be able to see that string. And that's what it's called a submucosal tie. And here you can, sorry, here's that chin. Here's his chin. If you can see that, see how far back his chin is. That can explain why he's having his mouth open more and why he has that noisy breathing mostly. Anyway, so we finished our exam and we said, okay, there's something going on here and mom doesn't want surgery. We don't want to do surgery. We want to make sure we can get the body tension and release and make sure the nerves are working properly. So our plan was to have that non-surgical baby legs therapy for about 6 sessions and see the cranial osteopathic physician so she could take care of that occipital condylar compression, which obviously you can see from his birth story that he did go through a quite traumatic birth experience. And we also wanted to make sure that the mom was keeping the nose clean so it'll be easier for him to breathe through his nose. And part of what we would use to improve his function while we're doing the baby led sessions would be what's called a baby munchie, which is a tool, like it's guiding them to be able to sort of first stimulate the brain and also help them learn how to keep their nose, how to keep their lips together as well. So by the time we had the 4th baby led session, the osteopathic physician was like, oh, okay, we can't really I can't do any more work on him. His body is no longer responding because the tongue tie is too tight for him. The restriction was too tight. So at that point, we had to let mom know that we're going to have to do a surgical procedure, which was something she did not want to start with, but which became necessary anyhow. So we did do the procedure in our office. We did the baby led session before the procedure. And after the procedure, they're gonna have to come back 3 more post-op visits anyway. And baby was fine. He reported time. He was better latching like right away. And when he came a week later, he was still fussy some, but mom said no, she didn't have any more discomfort at all. And that she felt that the jaw had gotten stronger. All right. And so again, by the second post-op, things were going much better. Breastfeeding was going well. We could both see that the jaw was coming forward. The mom was continuing to do the exercises. She said he was still upset with the exercises. That's something quite common with them. But she said that he was happier. He wasn't spitting up anymore, and his lips were getting closed, and he was breathing more through his nose. He was making more sounds like imitating tongue motions of his parents. So he just was like opening up more of the baby that he's supposed to be, right? And so by the 3rd post-op, you could see him laying down easily. His face was a lot more relaxed. His lips are sealed. And he did lose his munchie that we gave him, but we gave him another one. He was no longer tossing and turning. He's breathing and sleeping well, mom said. And he wakes up happy. He doesn't have hiccups. He doesn't have spit ups. His tongue was clear. So parents like, we don't have any more concerns, which is great. And we don't end there, because at that point we're looking, okay, we've gotten good function and we want to maintain that. So then we have them come every 3 months, keep using the munchie, and that allows us to make sure we get to when they have to start the solid foods, that we make sure they're using more whole foods to help the jaw to develop. And this picture here is just a summary and of what his face looked like. The picture number 1 was at his first initial visit. And if I draw a line from his nose going down, see how far back his jaw was, and that's pushing back on his airway. That's one of the reasons that when he lays down, his mouth is always open, and he has that noisy breathing as well. And he's got sessions of baby lays, and this picture here is after he'd had 4 sessions of baby lays, and he started his munchie and osteopathy right after the surgery. See how much his jaw came forward. And so he continues to grow in that manner. By the 3rd post-op, this is that 4th post-op. 4th picture was taken at the 3rd post-op, which here now you can see that the face is much more symmetrical. His jaw has come forward. He's actually right in front of the line, which is where you want both jaws to be. And that means his growth trajectory is much better. If you can think about it here, going from here where it looked like his neck and airway is being squished, now his face is more forward. So he has a lot more space to be able to breathe and grow in a manner that he should grow. And that's really important, because now you've changed his trajectory. You want to continue that by making sure he's still doing the good function, good swallow, and getting to solid foods when the time comes. So again, as I said, mom came in wanting to know about the baby lace procedure. And it is actually, we call it the cutting edge without cutting. But what it does is using a laser light of a certain frequency, is a 1064 nanometer laser, and it's a non-surgical technique. It just uses light energy. And I know a lot of people are familiar with like red light therapy and things like that. And so what it does in particular, this particular wavelength goes deeper into the body fascia to be able to improve the restrictions by enhancing blood flow and nerve functions in the body. But it's not just pointing the light. It's really, one, a specific wavelength and a very carefully sequenced technique, very intricate. And so very important, but also very helpful. Though it does have that added almost like photobiomodulation concept, but it's a lot more involved. It helps to optimize the nervous system. It helps with the tongue tie assessment, because when you remove the fascia, then you're able to see what is actually the restriction, like we saw in Javier's case. And anyway, I think that we couldn't say enough about it. Again, it allows us to be able to distinguish what baby needs to have an irreversible procedure, like getting surgical cutting or not. And even if we were to do the surgical procedure, it allows us to be able to identify the restriction is a lot clearer, and that makes your surgical site a lot less, and that just means that better recovery for the baby.
Wow. Okay. So I just have 1 or 2 questions, and then we can wrap it up here. But the first question I have is, when it comes to, mothers who have issues with breastfeeding, their first thought is not to go to a pediatric dentist. Their thought is to go to a lactation consultant, a lactation nurse. That's what the hospitals kind of direct them to. So what can the mom kind of look for so that they can say, this is something I might need to go to a pediatric dentist? Or what can the lactation, and our lactation nurses being trained to see these symptoms so that we can then say, let's go and get the tongue tied worked on, or let's get the fascia worked on?
That's a great question. So usually their first point of call would be the lactation person. Again, that's who the hospital will direct them to. And now these days, a lot more of the lactation specialists and consultants are learning more about the effects of tongue tie and what to look for in them. But generally, the very savvy ones, they could already tell it from a mile away, and the other ones may not be able to know that. So for a mom, if the lactation consultant has helped you change direction, change positions, did different things to help with milk supply and baby feeding, but you're still having pain. Breastfeeding should not be painful at all. It should be enjoyable. And so if you're having pain and your lactation person has not told you that, you should go seek help for that, considering a tongue tie or body function restriction, body fascia restrictions, then you should consider having to see a dentist who's trained on this, because you don't learn this in school. It's important to know that we don't get that training in school. We just chose to learn more about it, because understanding that how well we breathe and how well we sleep depends on how well our faces grow. And what we had already explained, the face grows from the base of the cranium, and your tongue function is an important part of getting that growth to occur. And so knowing that the earlier that you can intervene, the better that child's life is going to be. So
the next question is, when it comes to, having a newborn, there's a lot of decisions we have to make. And one of the biggest decisions is, okay, so we found out, right, through your pediatrician, or even the OBGYN, hey, your child has tongue tie. What kind of questions do we need to ask as parents to determine who to go to get this tongue-tied issue resolved? And I say that because we have, pediatric ENTs, we have pediatricians, and we have pediatric dentists all doing tongue-tied, or at least they advertise as doing tongue-tied, right? And so a mom could be overwhelmed, or a dad could be overwhelmed by all the decisions. What questions would you ask whoever in order to pick the right provider to do this procedure?
Well, I think that's definitely the dilemma that everyone has. And really, it shouldn't be what questions they should ask. It should be what questions the provider is asking, right? How are they doing their evaluation, and what questions are they asking you? Because if they're asking you specific questions, you know that they're thinking in a way that's not just about the structural tie. That's not just about cutting and snipping because you're having feeding problems. You can feed a baby, right? Baby can get food. You can use a syringe. You can use there's a way baby can get food. We need to find out why are they not able to get it the natural way. And that sometimes takes a bit more detective work. And so your provider should be asking really good detective work and not looking just to cut immediately, right?
Mm-hmm.
Okay. And the last question is, when we're looking at this the science of occipital condylar compression, we're looking at all this, right?
Mm-hmm.
If you see one, you pick one. Let's just say my child is vomiting, right?
Mm-hmm.
When is there a number of them that we have to pick in order to say this is a problem and we need to go seek help? Or can it just be one of the issues? Can it just be, hey, my child has colic, that's an issue, or my child vomits and that's an issue? Or does it have to be multiple symptoms, in order for it to be an issue?
No, usually it's not just the one thing that's going on. So
Okay.
usually multiple things are going on at the same time. And so if you fed a baby like especially if you're feeding them off of the bottle and you sort of kind of almost like pour that food inside of them quickly and they throw up right after that, obviously, that was from what you just did, the way you fed the baby, or they ate it too quickly. But if you're feeding the baby and you're pacing their feeding and you fed them and then after feed, they just throw up. If they throw up right after feeding and you've just fed them in a normal way, for the most part, it's because they just swallowed a lot of air. And if they're swallowing a lot of air, that means they were not able to create the vacuum seal, which means the lips not working properly, or the tongue's not working properly, or both are not working properly, so that they don't have to swallow air when they're eating. And so that's a problem. If they throw up, like they've eaten and then it was already maybe a half hour when the food should already be in the belly and they throw up, that's more likely part of that occipitocondylar compression, because that goes to be telling you that the vagus nerve is compressed. So it's not really able to do its work the way that it should do it. And so, yes, it could be one or all. Some babies have all of these things, and some babies have just one or two of them. But again, breastfeeding should be comfortable for you and for the baby. Sometimes I don't take too much into account of the mom, what they're saying, because sometimes I tell them they have boobs of steel, because as a mom, your first instinct is just to feed your baby. So you're not thinking about the discomfort. So.
Okay, and I promise this is absolutely my last question. I promise.
So we're here. We're good.
you know, so not everybody breastfeeds, right? Not everybody breastfeeds. If you adopt or if you just don't want to or cannot, right? We'll assume that that's the case.
Yes.
And you basically bottle feed.
Yes.
We know that we don't get mastitis from that situation, but what can we actually do? What are the symptoms? And can we use the same exact symptoms that are listed here to determine if we have a problem, if we have to take the mom out of the equation?
Yeah.
Or if we don't even know the birth story, right? Because maybe we adopted or whatever it may be. If we take the mom out of the equation, what are good ways to kind of determine that our child needs help?
Same things happen. Sometimes they will even have trouble using the bottle. That sometimes the baby is just struggling to use a bottle as well. So that was a great question, a great point, because yes, sometimes breastfeeding is not feasible. And the one thing that we do advocate, at least in our practice, when breastfeeding is not feasible, is to choose the bottle with a nipple that is closely shaped to be able to help with the same functions that your boobs inside the mouth would have done. So that's the only caveat, but the symptoms are just about the same in the most part, because if they don't have a good seal, they can still swallow air when they're taking the bottle. Sometimes they're not even able to take the bottle properly as well. And most moms will know that too.
That's awesome. Well, thank you so much. I know this was not easy with your schedule, but I just felt like this was something that needs to be discussed, a kind of continuation from the podcast, so that we can again continue to educate and we can give it to the different Facebook groups of moms of this and moms of that, because I do believe that sometimes moms feel isolated when they're having these issues, or they just fight through it, and so that's something that I think it's okay to say, hey, it doesn't have to be a struggle. Sometimes we think that parenthood has to be a struggle, and you're basically saying, motherhood and breastfeeding and stuff does not have to be a struggle. And so then these are factors that we can kind of look at. So thank you, ladies. I really appreciate your time.
Oh, the pleasure is ours. Thank you
for having us again.
Anytime.